Hello, everybody. Thank you for joining. And what you'll see is that all your videos are on and probably your microphones. But just for this event, if you want to just turn your videos off, that's absolutely fine. And then we'll get started. So if you would like to turn your videos off, so I'll go through and turn some of those off. And as we go through it, what will happen is I will sort of rattle on through all of my thoughts on this topic, and if you have any questions or if you want to make a comment, there is a chat box, you can do that, but I am here facilitating this on my own, so I probably won't be able to interact in the chat whilst I'm speaking, but then at the end of this there'll be an opportunity for questions. So I will close the PowerPoint down, and if you've got a question or if you want to have a discussion about something, then we can enter into that and you can decide as to whether you want to put your video on for that or not. The presentation that I do, I mean, I use the word presentation loosely. That will be recorded and I will send you a link to that so you can watch that again, but the question and answer session won't be, so I won't be including that in the record. So don't worry if you're feeling nervous or you're not sure, that's fine, you know, whack on your video, let's have a chat. None of that will go out in the recording, so hopefully you can feel comfortable. I'm just going to hold on for a minute or two because it would be nice to have a couple more people in. So I hope that you're all well. Thank you very much for coming along and for signing up. These sessions that I'm hoping to run over the next few months, perhaps even the rest of the year. It's just a real exploration of some of the reading that I've been doing and the things that I think would be useful. Part of my role is as a clinician, but what I find I'm doing more than that at the moment is sort of individual supervision work. So I'm working with individual clinicians who are struggling with this sort of movement and transition from their biomedically trained MSK approach into a sort of biopsychosocial approach, and what does that mean and how do we integrate it? And you know, we've got the kind of theory and the words, but actually what does that look like in practice? So that's what I've been working on a lot. And some of these sessions that I'm going to do over the next year are sort of springing out of conversations that come up there. Right, okay, enough rattling. I will share my screen and we will start to move through it. So hopefully you can see this now. So the title of this talk, The We, is a bit of an unusual title, I guess, but I've been thinking a lot about how we create relationships with people and how this is nurtured, or what needs to happen in order for us to have this good client-patient or clinician-client or clinician-patient relationship. So I wanted to talk about this without it feeling, because the sort of accepted term is this idea of therapeutic alliance, and we talk about this all the time, and I use this term so much. But I wanted to sort of flip that a little bit for this talk and see if we could come at this from a different angle. So like I said, my name is Laura Rathbone and I am a physiotherapist by training. So I did my undergraduate training and then I did my advanced NMSK training, which is a kind of critical reasoning muscle.
Sorry to interrupt in the middle of it, but I'm seeing 3 different things at the screen at the same time. So I think I'm seeing your slideshow and not the one that is for us.
Oh, thank you very much.
I'm seeing like the next one and the notes, all your presenters' notes.
Okay, hang on. If I do this, is that better?
Yes, perfect. Thank you.
Oh, thank you for telling me. Thank you very much. Right, okay. Oh, lovely. That's really, I'm glad you told me that because that would have been awkward all the way through. Thank you. So yeah, I teach as well a little bit. So I've been teaching at the University of Nijmegen, as Ben Cormack calls it, or Nijmegen here in the south of Holland, and on other courses around. So I teach on the a guest lecture on the clinical masters for psychology here in Amsterdam, as well as on the Nottingham University pain module. I also part of this thing called Le Pub Scientifique, which is a group of us, so alongside Tim Beams and Steph Polton and Bart van Buchem, we oh, I can't let this person in. We deliver these sort of learning events. So, and I also host a podcast called Philosophers Chatting with Clinicians. So I started this podcast 2 years ago, where I would invite a philosopher, somebody working in philosophy of science or philosophy of mind, to talk, and we would have a clinical chat and see what is the gap between us and how can we cross that, and make it, figure out what philosophy can teach us as clinicians, and vice versa. You know, what can we do to help philosophers, because they're thinking about these problems, but they don't necessarily have access to people, you know, out there on the front line working with these conditions. And then I also do, oh my goodness, what's going on here? Why can't I move? Okay, and then I also do this thing called Pain Geeks, which is a reading project that I released this year. So people that just want to read as wide as you can about this experience of pain, so that we can so that we can learn more and more about what it is to be in pain, what it is to work with people who are experiencing pain. And that's what I do there. And I also teach the course Act in the Clinic. So some of you I know out there have been on my course. Thank you very much for coming to this. I will look a lot more nervous in this situation than when I'm in the course. So presenting is something that I'm wanting to practice, which is another reason why I'm doing this, because I want to get better at translating the work that's happening out there in the world of philosophy, and integrating that with our clinical practice. So hopefully I will feel less nervous as I move through this. This topic, therapeutic alliance, like starting to research this was a bit like falling down a rabbit hole, and it just took me on a spiral that I wasn't necessarily expecting to be on. I thought I knew what this therapeutic alliance term was and have been using it for my entire career, using it with clinicians, using it with patients. It's been something that has been, I thought I knew it was. And then I started looking it up and I thought, this has got a different history to what I expected. This comes from a different place. And actually, sometimes I wonder if it's not a little bit problematic. So hopefully you will enjoy this journey with me. Okay. This session absolutely was inspired by this particular episode, journal. The Philosopher, which came out last autumn, had a whole piece on this idea of we. And if you haven't checked this journal out and you're interested in philosophy and what it might bring to the clinic, although it's not specifically aimed at clinicians, it is a philosophy journal, it's really interesting, and the articles are written in a really nicely accessible way. So I do suggest you check it out. But this particular work from this session was the work by Dan Zahavi, Regina Srinivasan, and Brooke Holmes, Thomas Santi, Donovan Irvin, and Faye Bound-Alberti. These pieces just really stimulated my mind to think about the connection and relation, this interrelational dyads that get created by people. The other thing is, I'm not a philosopher and I'm talking about philosophical concepts, and I'm not a psychologist and I'm talking about psychological constructs. So if you see an error, please do me the massive favor of reaching out and letting me know. Some of you out there will be further ahead in your reading in certain topics than I am, and some of you will be in a different place, maybe further behind. And so hopefully there's something interesting and a thought-provoking session that comes out of this, but please do correct me, because that will help me as I move forwards. So first of all, I want you to just think about the term therapeutic alliance. So maybe even just close your eyes and just run the words over your mind, like therapeutic alliance. What does that mean? How does it feel? When you think about this thing, this therapeutic alliance, what sort of emotions does it bring up in you? How does it feel in your body, in yourself, to think about this idea of therapeutic alliance? And now I want you to put that to the side and for a moment, just think about the word we. What does we mean? To be part of a we, to have a we. And I ask this because this is something that I experienced whilst I was thinking about this. I had the sort of the wee bit in my mind from the journal that I had just been reading, and I was also thinking about Therapeutic Alliance. And then I asked my husband, who's not a clinician and who has experienced care and is in care at the moment, so accessing therapy, what does it mean to you to think of the word therapeutic alliance? And it was really interesting what he said. He sort of came up with this idea, well, it's like a kind of cold battle. I have my allies, I'm allied with these people, and then these alliances are against each other. And I was interested in that because I had never even thought that that would be how people conceptualize this. But I could understand what he was saying as he said that. I could understand where he was getting that frame of reference from. And then I said, well, what does it mean to be in a we? And he was like, that's my family, it's my community, it's the trusted people, the people I choose to have near me, the people I let in. And I think that got me really excited because I'm a total nerd. But that's exactly it. It's that difference between this kind of theoretical, almost medical relationship that we're kind of trying to sort of create in a therapeutic alliance. And then there is this kind of we-ness, this we're in it together bit, this we are going to work on this thing. And I think as we're moving into a more compassion focused era of psychotherapy, this is probably something we need to conceptualize and be aware of as we think about how do we optimize these relationships, and even can we. So I had these questions in my mind. What do we mean by therapeutic alliance, and where did it come from? Is therapeutic alliance the same as we? And what is we? Does nurturing therapeutic alliance result in a stronger collaboration between therapist and patient? Do people identify as a we with their therapist? This one really interested me. And can we train people to be good at forming therapeutic alliances and or we's, and is that measurable? So in no way do I think I have answered any of these questions in this webinar, because these are massive, massive questions. But I started trying to look into the research and find evidence for some of this stuff and theories, mechanisms of working. So a lot of this idea around the client-patient relationship came about in the early 1900s. And then in the 30s, Sol Rosenberg, a psychotherapist, psychologist, was looking at the way that they were practicing at the time, the sort of psychotherapies that they were practicing at the time, and thinking, well, are we actually doing what we think we're doing? So he had these questions and these wonderings, are the factors alleged to be operating in the given therapy, are they actually the factors that are operating? So if we're thinking about, let's say, for example, a particular type of psychoanalysis, is that the thing that's actually operating as the mechanism of change, or is there something else going on? And then was wondering whether the factors that actually are operating in several therapists might actually, do they even look like this active treatment that we're thinking they're doing, or are they a completely separate thing that's just happening under the surface? And this gave birth to this idea of the pan-theoretical concept and these common factors theory. So operating across the therapeutic border, these common factors of therapy, of which one of them is considered to be this alliance, this client clinician relationship. And it's a kind of unseen process that's at work within the therapy. Now, this isn't new to us in MSK therapy at all. Like, we see this in low back pain, where we know there is no one particular exercise, no one particular treatment that has come out on top. Most of the approaches we take seem to have kind of equal amount of effect. So there's something common to the experience of coming into physiotherapy or rehabilitative practice that might be sort of facilitating change that we can't see or name at this point in time. So so this work by Rosenbach was followed up again in the 70s by Luborsky, and then again in 2006, and again sort of showed the same thing, that there are these common, like, unseen processes that are happening across psychotherapeutic approaches, even when those psychotherapies are different or conflicting. And we've seen this most recently in the Cochrane review for the sort of psychological approaches for chronic non-cancer pain, which came out, I think, last year. And it showed that CBT and other behavioural therapies like ACT or mindfulness-based therapies, behavioural therapies, they first of all, they're not showing great outcome, but they're also showing similar outcome. So it's not necessarily the approach, it's the common factor that's coming across the board. And that's what's really interesting to me. So what is that? Because is it how we do our therapy, or is it that we should just do some therapy? And is it in the act of doing some therapy, are we also bringing along with it these unspoken common factors, like, for example, clinician relationship and therapeutic alliance, if we're going to call it that? So I really nerded out quite a lot to this. So I wanted to know where therapeutic alliance came from. So way back in Freud, so of course this comes back to Freud, right? So we are so dominated by Freudian theories, we don't even know that we're dominated by them anymore. So the epistemology of Freud, the knowledge of Freud and the model of Freud has somehow over time transitioned into our construct of truth. This is just how the mind works. And you see that in pop psychology, or in amateur sort of armchair psychology, where people are sort of talking about each other's minds and how they interact. You see these elements of Freudian theory, this sort of psychodynamic theories. But way back in his earlier work, he talked about the importance of establishing this relationship with the client and coined the term transference. So this is a really contentious term, and there's lots of thought about it, but just to sort of stick to this model, so we're just sticking to his earlier ideas of transference. It's these unconscious redirecting of sort of emotional connection to another person based upon earlier interactions. And it was originally conceptualized as a positive attachment. So in Freud's earlier work, we wanted patients to attach to us in this way that they have had attachments before. And he even says in his work that this kind of positive attraction clothes the doctor with authority. So it is the thing that sets up that patriarchal hierarchy where the doctor can bring the patient through rehabilitation and towards success. So this conceptualized model really was about this setting up of a hierarchy where the person or the patient would view the clinician through the eyes of a child that views a parental unit. And one of the ways that he suggested we do that is that the therapist or the analyst maintains this serious interest and a sort of a sympathetic understanding of the client in order to connect with the healthy part of the client and bring that person through. So you need to remember that at this time, Freud was working with hysteria and psychoneurosis. So hysteria, one of the oldest diagnoses for mental health that we know of, and the poor women of ancient Greece running around with wandering wounds and terrible things that were done to them. So this is this diagnosis, which actually wasn't removed from the DSM until the 1980s. So we were still believing that this is how mental health worked at that point. So later on in his work, he went on to shift to say that actually the client clinician relationship was probably based on this new relationship, this real relationship, which we'll see pop up a bit later, between the client and the clinician. And the transference is now sort of shifted into a potentially negative relationship. So it's getting in the way of what we want to do. Is we want to have this sort of almost clean relationship, this unbiased new relationship with the healthy part of the person, and the transference is what's coming out of the sort of the broken bits. So So this model really grew out of the idea that people are broken and that we are going to fix them. And it's just interesting to me that this is where the therapeutic alliance grew from, because it's not at all how I would understand this word today. So it's the manipulation, the synthesis of this relationship that has now become that allows the therapy to take place. It's going to aid the therapist to connect with the well bit of the person, and that's where the therapy wants. We want to dominate the well bit of the person, and that comes from this manipulation of communication, this sort of eye contact, non-verbal stuff, close proximity, all this kind of stuff that we talk about even today. And the most important thing is that therapeutic alliance, or this relationship, has now become medicalized. So it's this therapeutic medium in itself. It's something for us to use as therapists in order to therapize. And I always think that's really interesting, because it almost starts to take away the authenticity of the relationship as we start to sort of systematize what we're doing. And this sort of goes back to my earlier training, and I can resonate with how this gets trained, because it's how I was trained. The construct of therapeutic alliance didn't really form under that term until much later. And in the 60s, it sort of started to shift from a therapeutic alliance into this working alliance, which has this more dynamic feel, this more sort of symbiotic feel, I suppose. But transference is still a main theme, and then there are three processes: so transference, working alliance, and the real relationship. And that is the therapeutic alliance. That's how this working alliance works. So this transference, this unconscious redirecting of feelings. So, for example, a person might be fearful when around an authority figure because they've had bad experiences with authority figures in the past, and so they're viewing this new person through the gaze of the past. I mean, I don't know if anybody remembers, like, you know, the old sort of teenage magazines and all this, you know, don't blame your current boyfriend for your past boyfriend. It's that kind of stuff. Like, that's how dominant these sort of like these sort of earlier theories, I wouldn't say old, but earlier theories are within our sort of pop psychology and how we move around the world. So Jung then took Freud's work and developed this further, and really was thinking about the therapeutic context and how. And at this point, he was considering that within the therapeutic environment, this relationship between client and clinician, the transference is often this kind of attraction, and not only this sort of erotic sexual attraction, which can take place, but it's also this idea of like other things like rage, hatred, mistrust, parentification, I think is something that we see quite commonly within the patriarchal healthcare system, and also this kind of godlike or guru status. So this concept of transference, this relating to new people based on old examples, can be unhelpful within the therapeutic environment, but outside of that therapeutic environment, it's probably very helpful in terms of it's probably what is helping us to create sustainable relationships. So this is interesting as well, isn't it? So outside of the therapeutic environment, this kind of transferred state, this kind of transference of meaning and feelings from one person to another, is potentially at this point being theorized as helpful. But in the professional world, in the therapeutic world, it's something that is unhelpful because it's getting in the way of a real connection. And I just wonder whether this is where our professionalism of therapy came from, this idea of, you know, these are my professional boundaries, and we don't want to encourage this sort of unhelpful erotic transference or parentification of therapists. And I wonder if that's sort of where some of our training has come out of, because if we think about where we are now in psychotherapy and the sort of reintegration of compassion, we're almost having to retrain therapists to allow authentic connection and give people the permission to have an authentic connection. And I wonder if this tension has arrived from that. So we when we're creating these relationships, this alliance, we're thinking about without even realizing, there is this assumption and this deeper foundational conceptualization of therapeutic alliance as this sort of transference, and can we somehow manipulate the transference that is taking place, and is that something that will aid therapy or get in the way of therapy, or do we actually need to try and make a new relationship? And this is the thing that I think is really interesting. So moving back to this working alliance idea, it's actually the person's ability to transfer, to move between a transferred state and a real relationship, which is where the sort of the healing can take place almost. It's this idea of being able to observe and cognize that there is a kind of transference happening, and that this is a real relationship. Now, this is really interesting, because there was then this bifurcation, this sort of, okay, can we do this? Can people actually make objective relationships with new people that are not based on previous relationships? Or actually, is every relationship we're making a kind of transferred state? So, and that's important, because I think it changes how we set up the dyad, how we set up the relationship between us and the client. So if we're thinking that we can have these object relationships, what we're trying to do is to sort of implant ourselves in a person's intimate world without becoming part of that intimate world. We're saying, okay, all that stuff that's happened in the past, that's not what we're doing here. We're doing a different relationship now. Or do we want to say, yeah, all that stuff that's happened in the past is part of our relationship. Let's acknowledge this and let it in, and allow for this to happen. And I think this is the conversation that as therapists we should be having right now. And that's why I think it's important for us to go back into the history, because these past dominant models, when they're left unchecked and unexplored, they have a tendency to get under our skin. Like I said in the beginning, we just base our knowledge on this sort of ontology of truth, like, for example, that communication strategies and the manipulation of communication strategies will create this therapeutic alliance, this helpful new non-biased therapeutic relationship where we can do the healing with the healed person, rather than creating a relationship that's messy and chaotic and is somehow unpredictable, because the other person is being influenced by all of their other relationships, and it's only by this sort of allowingness of that we're going to create a therapeutic alliance. So how do we conceptualize the foundational knowledge of where this alliance is emerging out of or growing out of, I think is important. I was also really surprised to see that there is no kind of agreement on therapeutic alliance. There's lots of different ways of conceptualizing it. At the moment, when we look at some of the work in empathy training out in nursing literature particularly, which if you have never read nursing literature, just go out and read some nursing journals, because they're full of communication richness and how do we see the other person. But there's been a kind of move towards 5 tips for creating rapport, eye contact, nonverbal mirroring, all this kind of sort of strategizing of how do we synthesize these kind of reactions, and can we teach clinicians to cognitively choose to sort of to deliver communication strategies that's going to sort of nurture a kind of therapeutic alliance, or is there something else about this kind of relationship building that we're kind of missing because we're over theorizing it? One way of understanding therapeutic alliance, which I think this is one of the ways that I have sort of almost unknowingly been using, is the Carl Rogers modeling of alliance. And he came up with 6 core elements of the client the therapeutic interaction that were necessary in order to create a good bond. So this, and 3 of them are considered core. So the 3 with asterisks around are what are considered the core processes. So number 1, this idea of a respectful relationship, this client therapist psychological content, and this really is about the acknowledgement and respect for each member of the relationship's perception of the other. So how is the patient perceiving me, and how am I perceiving the patient? And those two things are important. And then as we move into this sort of like client incongruence, there needs to be something that we're working on, some incongruence between the client's experience and awareness of, you know, their interactions within the world. And then this therapist congruence and genuinity. So Rogers said, you know, you cannot just learn communication strategies and then deliver them and boom, an alliance will form. We need to approach these clinical interactions with authenticity and genuineness, and we're only going to do that if we allow the other person to see ourselves, if we allow the other person to see the clinician as a human, and this self-disclosure, and then this unconditional accepting of the person in front of you. So even if you think what they're doing, even if we would judge what they're doing, I don't know, if we wouldn't do what they're doing in order to manage their symptoms, or if we don't believe what they believe, or if we don't identify in the way they identify, the point is that in the therapeutic setting, we unconditionally and non-judgmentally accept and embrace that person. And this in itself is considered to be a therapeutic principle, because what we're doing is we're exposing this person to a value and to being valued in a way that they may not value themselves. And the fifth thing, this empathic understanding, like this is widely considered to be the most important thing, and this is where empathy training has come out of, and compassion training has come out of, this idea that the therapist must have this deep, reflexive, flexible, empathic understanding of the person in front of you, and that this needs to be sort of accurate. So we're not overly appropriating that person's experience, but we're able to see that we're able to acknowledge and validate and feel the person's experience in a kind of accurate and appropriate way. And I think most importantly, the client perceives us to be a person that is going to help, a person with whom, you know, a person who regards them as you know, a whole human and non-judgmentally. And I think this is something that we don't really have a measure for. We don't really know about whether the person that has chosen to work with us actually likes us or wants to work with us or trusts us. It's not always worked into our conversations, and perhaps this is something that we could be doing. But what Rogers is really calling for here is authentic connection, that this is not a communication skill, it's a feeling skill. And this is what brings me into this work around the we, and this, how do we have this moment to moment sort of development of relationship between us, and brings me into this sort of phenomenological approach of relationship building and experiences. Now, I don't know how much people know about phenomenology, and this is probably the first time that I've publicly tried to explain what phenomenology I think is or means. So remember, I'm not a philosopher, I will make mistakes, please correct me, but also hopefully this is just an opportunity to stimulate your own reading and your own interest. But literally phenomenology is like the idea that phenomena appear or show up for people based upon their experiences, and the way that we experience things and the meanings that they have within our experience is seen from the first person. So often what we're having within MSK therapy is that we're taught to observe what's happening in that person and then make our decision as to what's wrong with them, or what's going on, or what might be the cause of their symptoms. And a phenomenological approach would be that they are able to tell us what's happening. And it may well be that we have some kind of diagnostic label that we can give that, but it's not only through our observation, it's actually through their experience. So for example, when we're seeing somebody with chronic pain, but they don't necessarily have the observable changes on a scan, the person is telling us they have chronic pain and therefore they have that. And the pain exists and shows up to them the way that they tell us it does. And so that would be a clinical example. Another one would be, say, for example, the world around us is here, and this is why it's not a Cartesian approach. So this sort of Descartesian, this Cartesian idea of the only thing that I know to be true is me, it's the I, it's the self. In phenomenology, what they're sort of saying is the world exists and we know that it's out there, but it's the way that I interact with the world is based upon myself. It's based within my learning and my experiential movement through the world, and that will develop the action potentials or intentionality or affordances that show up within objects. So if I give you an example, of this cup. So this cup exists and I am able to interact with it. The affordances of this cup are dependent upon my ability to interact with it. So what am I able to do? But also the context within it. So for example, I have the ability to reach out and grab it, therefore the affordance of taking it and drinking with it is afforded to me. It's a vessel, so it can hold fluid. And so the affordance of drinking that fluid is implicitly set up within that relationship. It also has the ability to hold pencils. And if there were pencils in this cup, then the context of the cup changes, and my ability to interact with the cup, the affordance changes. And it doesn't necessarily have to be objects. So if we look at the work by Rietveld and Kirstein, they're sort of, saying that this landscape of affordances can be people or social interactions, social environments. It doesn't necessarily just have to be a sort of physical object that we relate to. And that's interesting when we think about how do we set up these relationships. Perhaps part of the relationship process is afforded to us within that way. So I will afford a type of relationship to you as an individual that might be different to another individual that I also have a relationship with. And so it's not necessarily about the authority that I hold, or it's more about your experiences. And that sounds a little bit like transference to me. But it may well be that it's not something we can manipulate, or is it? And this might be an opportunity for us as therapists to think ecologically about how we create environments and whether we can optimize the space and landscape for these relationships, which I just think is really super interesting. So I did a podcast recently with Teresa Ioko and Martin Ongwen. So the podcast Philosophers Chatting with Clinicians, it's on Spotify, and hopefully there'll be more this year. So I did a podcast with them and we were talking about how pain is conceptualized out in tribal communities in their local area. So they're living in Kenya, and they were looking at, particularly Martin works out with the Maasai tribes, and talking about how they conceptualize pain is very different to how we conceptualize it. But there is this Nguni Bantu term, which is Ubuntu. I am me because we are we. And Dan Sahavi brings this up in the article within The Philosopher as well. And essentially what's happening, what we're saying here is that the we is forming based around this concept of the I. And I always think maybe I really did go down a rabbit hole with this. So I was really thinking, well, what is this thing we? And how do we, if that's the common factor, if that's the thing that we're saying, therapeutic alliance, the client-clinician relationship is important, then how do we form these we's, and how do we form these relationships, and what is that made up of? And so this there are a couple of things within phenomenology, there are a couple of perspectives on how sort of groups connect and groups work. So if we think about this particular term, I am me because we are we. So I am whole because we are whole. And the wholeness of we is interacting with the wholeness of I. So this kind of saying sort of says there is an individual and then there is a we. Really interesting, because philosophically we just don't know how to actually, how do we actually put lines around this? How does this work? How do we theorize this? So Heidegger would put this in a different way. He would say the other is not there is no such thing as an other. it's not a person that I take to be like radically different. It's not like I'm a person over here with all of my beliefs and dreams and selfness, and then there's a person over here with two totally different entities. He would say that actually those people are identified together because they share the world together, and they share different aspects of the world, and sometimes that shared world is very close and sometimes that shared world is very far, but essentially we are kind of one as a kind of Mitwelt, this kind of Mitsein, this we are together. There's some criticism of that, and a different perspective would be more like a Husserlian perspective, who talks about like this intersubjective space, that actually I am I and then we are we, but there is no sort of like molding or meshing. We don't share a kind of cognition or a kind of identity. What's happening is we're kind of subscribing to a uniquely created identity between us, and that would be that intersubjective space. And he coins the terms, and I think it's beautiful, thought communities, that we subscribe into these thought communities, and we have loads of them. So we're developing one right now, even though it's a kind of a weird one because it's virtual, but you're out there. I'm putting the me up here. This is something I'm interested in. This is what I like to learn about. This is what I think about the world. These are my ideologies and perspectives and how I make sense of the world. And you're out there thinking, well, this is my ideology. This is how I, it's like, do I agree with that? Do I identify with that? Am I subscribing to this thought community? And in this moment, we're starting to create a very modern technical we, or not, might be the case. And fair enough. so these we's are kind of, they're dynamic, they're extended, they're shifting and changing depending upon the individuals within. So I wanted to share a quote here because I thought this was really interesting, but I know I'm running out of time, but I would like to share it anyway. So Kay Tempest is a beautiful writer, and she just wrote on connection, and I actually got the opportunity to see her perform it. And she writes, when I write characters, I'm always trying to pull out the tension that exists between their interior lives, the small exchanges, private hopes, intimate relationships, and their exterior lives, the impossible largeness of the environment that they exist within, and the day-to-day reality of what they have to do to get by. I don't think there is any more beautiful way to describe the place of this place where therapists work, where we function. We're sort of somewhere between that other person's private, deep, intimate space, and then how that private, deep, intimate person exists in this wide, massive potential world that they can move around. And so in order to be able to, we have to subscribe to their private place and their external world as well, their wider world. But they also have to subscribe to our private place and allow this relationship to develop. And I'm just not sure eye contact is going to cut it when it comes to creating these really deep connections, because this authenticity is what is required. And I think this is the problem with psychotherapeutic models, is the very fact that we want to communicate it from one person to another means we have to sort of strategize it. But how do you strategize that moment where you decide we are we? So I am part of you. You are now allowed the sort of relationship status with me that I also give to my loved ones or my children or my community. You are now allowed or afforded that space within my world, and also I am going to engage with you in that way, and there has to be this kind of exchange. And so we're moving very, very far away from this idea of a patriarchal therapeutic alliance. I'm going to manipulate communication in order to make you better. And we're now moving into a kind of we-ness, a collaborative, intersubjective space where we're going to acknowledge that this common factor of therapy is probably something to do with authentic connection. And in order to allow that to nurture and flourish, I almost need to have permission to do that as a clinician, especially if we've been trained differently. And when I was researching this topic and thinking about this quote came to me from the piece by Rogerian Srinivasan. Like, this we is just, it's immeasurably larger than we think it is and much smaller than we hope. So everybody knows what we means. It means a person and another person. But does it mean a person and another person? Or does it mean, is there some kind of existential change that happens within that relationship? Even if it's temporary, even if it's just for that split second on a train where you just make eye contact with a stranger, and in that one moment you've just both subscribed to allowing a little bit of we-ness to happen between you. Or when we're thinking about this therapeutic environment where somebody is coming to us with their most vulnerable place and saying, I need help. You know, how do we conceptualize that, and actually, can we train it, or is it just a kind of feeling skill? It's a space that needs to be given in order for this feeling skill to nurture. And are we doing that in our therapeutic trainings? Are we actually teaching that skill? Are we nurturing that feelingness of human connection? Which was my next question. Can we teach this? So I don't want to go on too much because I know I've already gone on for a really long time, but you know, this idea of empathy training has become quite modern at the moment, and there's some evidence that it changes the way people behave, but it's not consistent. There is some evidence that it doesn't change anything at all. And I think there was a piece by Zahavi, not the piece that in The Philosopher, a different piece, a piece that actually was on Pain Geeks in the first week, that was talking about basic empathy. So empathy from this phenomenological perspective. So we talk about empathy at the moment as like a cognitive thing. So I can theorize what the other person is thinking or feeling, or a kind of emotional thing. So I can emotionally experience what the other person is experiencing. And Zahavi calls for this and different idea of basic empathy. This idea that I just acknowledge that that person is expressing a kind of emotional state that I don't need to feel, I don't need to have it to empathize with it and to understand it and to relate with it. Just need to acknowledge that that's what they're demonstrating. And he gives the example of you know, you're walking down the street with your friend and a dog runs past and the friend goes like that. So a cognitive empathy would mean that you are theorizing that the sort of tensing of the muscles and the holding of the breath must be meaning that they're afraid, and you're associating that fear with the dog. And an emotional idea of empathy would be that you are able to feel the fear of that person, and so you know that they're experiencing fear. And a more basic empathy would just be like, wow, that person's body is expressing fear, and we're able to just acknowledge that human to human, rather than having to have this sort of representation of it, or this kind of strategy for synchronization and implanting us in the other person. We're able to just acknowledge phenomenologically that that's what's that is what that expressive body is able to share with me. And that, so it's again, it's moving away from this Cartesian modeling, this idea that the body is not a thinking process, it's just a doing bit, and the mind is the doing bit. But actually, if we consider the body as an expressional place, it starts to sort of change how we make connection. And so when we're training empathy, if we're training people to theorize over it, it might mean that that gets in the way of actually just acknowledging in the moment what's happening, especially when we think about situations where the theory doesn't necessarily make sense. So, for example, in pain, if the theory is that there needs to be some damage and then there is no damage, or no damage that we would classify it through our current modelling of pathoanatomy, how do we theorize or understand or empathize from a cognitive perspective that person's experience? And it might be that we can't, and so it might be that we start to deny that experience and say, well, you know, there must be something else going on, or this can't be pain because it's not damage. And we're seeing that happening out there, and people who are going through our services are telling us that this is what they're experiencing. Or it might be that we're over empathizing and we're almost taking on the pain of somebody else. In order to acknowledge and validate that person's experience, we're having to almost go into their experience, and that might not necessarily be an appropriate amount of empathy. And so what if we had this other space, this other way of training people to have empathy? And I don't know the answer to that at the moment, but I have a feeling that it's probably something to do with a kind of understanding of psychotherapy, a kind of understanding of MSK rehabilitation principles, and a kind of understanding of social determinants of health, which sounds a little bit like the biopsychosocial model, which would be how I would segue this if we had 7 more hours to talk about it, which I kind of wish we did. And can we measure it? So there is something called the Working Alliance Inventory. It's being validated for psychology or psychotherapy, but there are some construct validity issues, and it hasn't really been validated for rehabilitation, and there are some issues as to whether this is translatable. But do we need an alliance inventory to ask people whether the relationship is working between us? Is this something we could just ask people? Do you feel safe with me? Does this relationship seem right for you? Do you feel like you are able to share your intimate thoughts? And if they can't do that with us, then maybe there is a role for somebody else to ask about our relationship. I don't know, but I feel like it's hard for us to know if we're measuring what we think we're measuring. So with the WAI, what they saw was that improved scores on the actual measure didn't necessarily translate to a reported feeling of alliance. So there's a construct issue here. It doesn't necessarily tell us what we think it's telling us, so we can't rely on it for information. We probably just need to feel whether this other person is able to express themselves and feel safe. So that was a really fast run through of some of my recent readings and thoughts on therapeutic alliance and we-ness, and I wish I could go on for like hours and hours and hours. There's a small amount of references that I used here, but I will, when I put the recording up, I will put a much bigger list of things for you to look at, and I hope that that's been interesting and yeah, stimulated some thought. Okay, I'll be doing another one next month. I'm going to try and do one of these every month. So next month, I'm going to do another one. So watch this space. You'll be getting an email letting you know when that is and how you can sign up to it. So thank you very much. Have a lovely day, everybody.